posterior surface, this is your medial condyle, your lateral condyle. This is called the intercondylar space. Between the two condyles, it's called intercondylar space. So this is all about the femur or the thigh bone. Please remember, it's the longest bone in the body. This chart shows you the thigh bone or the femur. Okay. Now, as we have said, this is the head of the femur. It fits into the acetabular cavity. Okay, and it forms a ball and socket hip joint. So this is the head of the femur. This area here is the neck. Just below the neck you have a greater trochanter. Posterior surface, more prominently you have the lesser trochanter. Between the two trochanters you will find a bony prominence called the intertrochanteric line, joining the greater trochanter and the lesser trochanter. This is the anterior view, so this is the anterior surface of the femur. Posteriorly you will find the linea aspera. This is the lower end of the femur, and you have a medial condyle and a lateral condyle. Okay, this is the articulating surface for the patella anteriorly, anterior to the lower end of the femur. Now posteriorly on the lateral condyle you will find this area, which is the adductor tubercle. This is all about the femur or the thigh bone. The first part of the lower limb that we are going to study is the thigh. Okay. Now in the dissection of the thigh, the first layer that you will come across just under the skin will be superficial fascia. Superficial fascia of the thigh is divided into two layers, a superficial fibrofatty layer and a deeper membranous layer. There are two layers in the superficial fascia. Now both of them are continuous with the same respective fasciae from the anterior abdominal wall. Okay, the anterior abdominal wall has the same layers, and the layers in the thigh are continuous with the anterior abdominal wall. Okay, now there's one important area here that you need to know. It's called the Holden's line. This is present just below the inguinal ligament, and this is the area where the deep membranous layer of the superficial fascia fuses with the deep layer of the fascia of the thigh. Okay, so it's a area where it is the actual limit between the continuation of the fascia from the anterior abdominal wall and the thigh. Okay, this is the demarcation between the abdomen and the thigh or the lower limb. Okay, it's called the Holden's line. Now this superficial fascia has a number of structures. Okay, you can have the cutaneous nerves, you can have the branches from the femoral artery, the tributaries into the femoral vein, a lot of lymph nodes. Each of these individual structures we'll study at the end of the lower limb. Okay, the entire structure of the venous system, femoral artery will come to in a little while, the venous drainage, etc. will come at the end of the lower limb. For now, that we're going to study is the lumbar plexus, the branches of which are present in the superficial fascia of the thigh. Okay, so let's look at the formation and the branches of the lumbar plexus. The lumbar plexus is formed by the ventral rami of L1 to L5 spinal segments. Okay, L1 to L5 spinal segments, the ventral rami participate in the formation of the lumbar plexus. The first nerve, that is L1, splits into two terminal branches, that is the ilio-hypogastric nerve and the ilio-inguinal nerve. Now the next branch that we will see is the genitofemoral nerve, which comes off from L1 and L2. The ilio-inguinal nerve and the genitofemoral nerve can be found in the superficial fascia of the thigh. Okay, now we have the formation of two important nerves, the femoral nerve, which comes off from L2, L3 and L4. L2, L3, L4 branches unite to form the femoral nerve, which is the nerve which supplies the anterior compartment of the thigh. Okay, that is the extensor compartment of the thigh. Okay, The anterior compartment of the thigh is supplied by the femoral nerve coming off from L2, L3 and L4. Next you have this nerve, which is the lateral cutaneous nerve of thigh, which is formed by union of L3 and L2 terminal branches. L2 and L3 unite to form the lateral cutaneous nerve of thigh. Okay, then you have this nerve, which is the obturator nerve, which is formed by L2, L3 and L4. You have the obturator nerve. Now this is the nerve of the adductor compartment of the thigh, or the muscles in the medial compartment of the thigh. You have the obturator nerve, which is the adductor compartment nerve, and the femoral nerve, which is the anterior compartment nerve. Okay, now L4 and L5 ultimately join to form the lumbosacral trunk, the branches of which we will see a little later. This is the picture that shows you the formation of the lumbar plexus and the branches which come off from the lumbar plexus. Now the lumbar plexus is formed by the ventral rami between L1 to L5 spinal segments. L1 to L5 participate in the formation of the lumbar plexus. Now L1, the terminal branches are the ilio-hypogastric nerve and the ilioinguinal nerve. Only the ilioinguinal nerve is seen in the thigh. L1 and L2 join to form the genitofemoral nerve. These two nerves, the ilioinguinal nerve and the genitofemoral nerve, are both seen in the superficial fascia of the thigh. Next, you have the formation of a couple of important nerves, which are the femoral nerve and the obturator nerve. Femoral nerve is formed by L2, L3 and L4. Obturator nerve is formed from same L2, L3 and L4. Now femoral nerve is the nerve in the anterior compartment of the thigh, or the extensor compartment of the thigh. Obturator nerve is the nerve of the medial compartment of the thigh, or the adductor compartment of the thigh. Lateral cutaneous nerve of thigh comes off from L2 and L3, and the L4 and L5 nerve roots form lumbosacral trunk. These are the important nerves that come off from the lumbar plexus. Now after the superficial fascia, the next layer in the thigh is the deep fascia. The deep fascia of the thigh is also called fascia lata. Okay, the fascia lata is a tough fibrous sheath. Okay, and it is closely apposed to the muscles and the other structures in the thigh. Okay, now the attachments of the fascia lata are quite important, so it is better for you to actually look them up. Okay, now let's do certain important aspects of the deep fascia of the thigh. There are certain modifications in the fascia lata, and one such important modification is the iliotibial tract. Okay, the iliotibial tract. This is a lateral thickening of the fascia lata. It's a lateral thickening of the fascia lata. Let's look at the attachments of the iliotibial tract. Superiorly, it's attached. The superior part of the fascia lata is split into two layers, a superficial and a deep layer. The superficial layer is attached to the tubercle of the iliac crest, and the deep layer is attached to the capsule of the hip joint. Okay, it opens up superiorly and it finds two attachments. Okay, it encloses two muscles, which we will come to in a short while. Inferiorly, the iliotibial tract is attached to the sides and the anterior portion of the knee. Okay, and it is very firmly attached to the anterior surface of lateral condyle of tibia. So this is the superior and the inferior extremity of iliotibial tract. The applied anatomy of the iliotibial tract is that, one, as we have already mentioned, the superior part splits up and encloses two sets of muscles. A portion of the gluteus maximus, okay, a portion of the gluteus maximus and tensor fasciae latae. These are the two muscles which are enclosed in the superficial and the deep parts of the superior attachment of the iliotibial tract. The second important thing about the iliotibial tract is that it is very important in the support of the knee joint. It totally supports and suspends the knee joint in extension, and it also supports the knee joint in flexion. Now initially at the beginning of the class we said that the pelvis, because of its weight, has a natural tendency to tilt backwards. This is prevented by the anterior attachment of this iliotibial tract. Okay, it is the support of the knee joint, especially during extension. Now, the third important thing about the iliotibial tract is in surgical repair and reconstruction. Surgical repair and reconstruction. If there is a loss of tissue, it can be bridged by taking out a strip of this iliotibial tract and attaching it at that area where there is any loss of tissue. Therefore, this iliotibial tract is important in surgical repair. This picture shows you the attachments of the iliotibial tract. As we have already studied, the iliotibial tract is a modification of the fascia lata. It's a lateral thickening of the fascia lata. Now, this iliotibial tract superiorly is split into two layers, the superficial part of which is inserted into the tubercle of the iliac crest. The deep layer is attached to the capsule of the hip joint. The superior part of the iliotibial tract encloses two muscles which are the gluteus maximus and the tensor fasciae latae. Okay, these are the two muscles which are enclosed in the upper attachment of the iliotibial tract. Now, this is a lateral thickening, we have said, and it goes way down and attaches at the anterior surface of the lateral condyle of tibia. Now, because of its disposition, we can actually see why it is a support of the knee joint. It holds the knee in extension, in full extension. It holds the knee taut, okay, and it prevents the pelvis from tilting backwards because of its weight. So, the iliotibial tract is important in supporting the knee joint in full extension. Now, the other important application of this iliotibial tract is that since it is a tough fibrous tissue, it can be used to reconstruct and bridge gaps, especially in surgical repair and reconstruction in cases of loss of tissue. So, these are the important aspects of the iliotibial tract. One more important feature in the deep fascia or the fascia lata is the saphenous opening. That is an oval gap in the deep fascia. The measurements of the saphenous opening are about 2.5 into 2 centimeters. Now, the surface marking of the saphenous opening is important. It is 4 centimeters below and 4 centimeters lateral to the pubic tubercle. Okay, so that's important to remember. Now, the saphenous opening is important because of the structures passing through it. The great saphenous vein passes through it, and arteries like superficial epigastric and superficial external pudendal, which are the superficial branches of the femoral artery in the femoral triangle, pass through the saphenous opening, but they are not accompanied by their respective veins. Okay, superficial epigastric vein, superficial external pudendal vein do not go through the saphenous opening. In addition to these, there are a few lymphatics which drain through the saphenous opening. Now, the thigh is divided, okay, the thigh is divided by these, the extensions of the deep fasciae into certain compartments, into 3 compartments. These are called intermuscular septae, okay. There are 3 intermuscular septae which are continuations of the fascia lata. They are lateral, medial and posterior intermuscular septae. There are 3 of them. Now, they in turn divide the thigh into 3 compartments, anterior, posterior and a medial compartment. Now, all 3 intermuscular septae, they converge towards the linea aspera, which we have seen on the posterior surface of the femur. Okay, therefore this area is important because all the 3 intermuscular septae converge at that point on the linea aspera. The intermuscular septae divide the thigh into 3 compartments, okay, called the anterior compartment, the posterior compartment and the medial compartment. The anterior compartment is also called the extensor compartment and it is supplied by the femoral nerve. The posterior compartment is also called flexor compartment and it is supplied by tibial component of the sciatic nerve. The third compartment is the medial or the adductor compartment of the thigh, supplied by the obturator nerve. So these are the 3 continuations of the fascia lata which divide the thigh into 3 different compartments. When the deep fascia is dissected and removed, we come to the deeper structures of the thigh. Okay, now in front of the thigh, about 3 centimeters below the inguinal ligament, we come across the femoral triangle. Now this femoral triangle is formed by the medial border of the sartorius muscle laterally. Okay, medially it is bounded by the adductor longus muscle. The base of the femoral triangle is made of by the inguinal ligament. If that's the inguinal ligament, that's the lateral border of the sartorius, that is the medial border of the adductor longus. That is your triangle. Okay, it's called the femoral triangle. Now the apex of the triangle is formed by the convergence of the lateral and the medial borders. The base of the femoral triangle, as we have said, is already formed by the inguinal ligament. Now the roof of the femoral triangle is formed by skin, superficial fascia with all its contents, that is the femoral artery with all the superficial branches, the superficial femoral vein and its tributaries, and superficial lymphatics. Okay, these are all the superficial part of the roof of the femoral triangle. Now deep to the superficial fascia, you have the deep fascia, the saphenous opening along with the cribriform fascia. Okay, these form the roof of the femoral triangle. Now the floor of the femoral triangle is formed medially by adductor longus and the pectineus muscles, and laterally by the iliacus and the psoas, which together form the iliopsoas muscle. Now these are the relations of the femoral triangle. Now the femoral triangle is important because it contains certain important structures and it is present quite superficially on the anterior part of the thigh. Okay, the contents of the femoral triangle are the femoral artery and the femoral vein, which are enclosed in the femoral sheath as the contents. Okay, in the upper part of the femoral triangle, there is the femoral artery and the femoral vein, which are enclosed in the femoral sheath only in the upper part of the femoral triangle. Okay, there is a part of these artery and vein which are not covered by the femoral sheath. And you also have nerves, the most important of which are the femoral nerve and other branches of the lumbar plexus. Now what we're going to study is individual parts of this femoral triangle. We're going to start with the femoral sheath and the contents. This chart shows you the femoral triangle whose lateral boundary is by the sartorius muscle, the medial border of the sartorius muscle. The medial boundary is the lateral border of the adductor longus muscle. This is the adductor longus. Okay, now the apex is formed by the convergence of the lateral and the medial boundaries. The base of the femoral triangle is formed by the inguinal ligament. Now the femoral triangle is important because of its contents. The contents of the femoral triangle are the femoral artery, the femoral vein, the femoral nerve, and the femoral sheath, which encompasses the femoral artery and the femoral vein in the upper part of the femoral triangle. Now there are different nerves which pass through the femoral triangle. They are the lateral femoral cutaneous nerve, the trunk of the femoral nerve along with the branches, the muscular branches and intermediate femoral cutaneous nerve. The saphenous nerve arises at the apex of the femoral triangle. Also you will have the branch of the femoral nerve called the medial femoral cutaneous nerve. Now the femoral artery also gives off its main branches, the profunda femoris artery, the lateral circumflex femoral artery. Now the lateral circumflex femoral artery passes between the two terminal divisions of the femoral nerve. The femoral vein and the femoral artery are the contents of the femoral sheath. This is a fibrous sheath which extends 3 to 4 centimeters in the upper part of the femoral triangle. The nerve of Cloquet is present inside the femoral sheath. Important to notice that the femoral nerve is not a part of the femoral sheath, but it is present outside the femoral sheath in the femoral triangle.